First of all, thank you, Srikant ji. Thank you, Rashmi ji. I was in the midst of meeting, so I joined late. But if you permit me, I can share presentation for 5 minutes. If is it okay? So basically, I think it will be much better if I explain on the presentation screen sharing. I think it's view now. You can view the screen.
Yes.
Yes. You can see the screen. Yeah. So Nandurbar district is a tribal district. We have 6 blocks. Current population is around 2 million, and 70% population is tribal. In terms of human development index, is the poorest district. You can imagine for the 2 million population in government setup, we had only 2 MD medicine doctor. There is no medical college, no BAMS college, no BHMS college. And because of the hilly terrain of Satpura, a lot of issues of health issues were there. So we have only one district hospital, 2 SDH, 12 rural hospital. But when COVID started, 90% government hospital were already occupied by the regular patients like deliveries, cesareans, fever, malaria, typhoid. So it's very difficult for us to convert this regular hospital into the COVID hospital. So these were the issues. We were not having proper health infrastructure, no medical college, no RT-PCR testing lab, no oxygen plant. Very around 35% government vacancy was there in the rural health setup. Hilly terrain, people were illiterate, most illiterate district in the entire Maharashtra. So first thing we started, we set up our district control room. Initially, people were calling for a small reason to district collector. So first thing, this call actually, that frequency of call got reduced, and every day around 50 to 60 calls will directly go to the control room. They will note it down their problems and they will try to give the solution. And if some issues comes out, like about RT-PCR test, about availability of beds, then we had developed this dashboard. So this had taken in around 15-20 days back. At that time, 217 oxygen beds were available in 24 hospitals. Currently, more than 600 beds are vacant, oxygen beds. So in this dashboard, everyone can see block-wise, hospital-wise, which type of bed they want, ICU bed, oxygen bed, which type of ambulance they want, which vaccination booth they want. And in fact, High Court of Mumbai actually praised about Nandurbar dashboard system, because every hour, which hospital has how many beds vacant, that data gets automatically reflected. So this is the current scenario. In government setup, we have 258 beds in civil hospital. In periphery blocks, we have 161 beds. And in the entire setup, like in railway, rural CCC, total beds, we have around 6,700. And in private hospital, 902 oxygen ICU beds we started. So this is the current situation. Many beds were lying vacant, and people, because the caseload that we got in the month of April, in the first week, we are getting around 1,200 to 1,300 cases per day. Now the caseload is reduced since last 15-20 days, around 60 to 70 cases are coming per day. So how we had able to decrease that caseload? We had used this technique of using RT-PCR swab collection by going door to door. You can see the tribal woman who is staying in the village. So instead of she coming to our laboratory or our swab collection center, our teams will go to their door-to-door step. So around 16 teams were deployed for the door-to-door collection. Along with that, we had put our own centers which will collect the swab when people are coming to our hospitals. And along with that, around 29 mobile teams for rapid antigen collection we had put. So this was the situation a few days back, where 36,000 cases out of this 699 people were died. And in that entire scenario, around 1,000 patients who were detected and treated, which were outside of Nandurbar district. They came from Madhya Pradesh, Gujarat, Nasik, Jalgaon. So neighboring district people also started coming in Nandurbar because we have so many beds vacant. So these 200 contractual persons we recruited, health personnel, because we were having the shortage of the doctors and nurses. 86 contractual person done only for the vaccination and CCCs, because we were not getting any MBBS or MD doctors. We trained BAMS, BUMS doctors for the intubation, for the intensive practices. So this was the woman dedicated hospital we made of 250 beds, where only women patients will be treated, so that they will feel more secure. So doctor, nurses, everybody will be leading. This is oxygen facility where a lot of people were praising about that. So three government oxygen units we have set up, and two private units, like total 5 units. Four more units are in under establishment, under constructions. So every unit will start 600 liter per minute. So if you combine the capacity of entire all the 4 5 units, it will come around 48 lakh liter per day. At the same time, we got some concentrators also. So basically, those who are in the remote areas, we are using the concentrators which are in the hilly terrains. So my motive was that every hospital of government setup, all RH, all SD should have some oxygen beds. And the people, instead of coming to the district, they should able to take treatment in their own area. This oxygen nurse pattern, which was praised by the health minister and the Niti Aayog, where we had put dedicated nurse only for monitoring oxygen, to reduce the oxygen, to increase the oxygen for all 50 patients in one hospital. The work only is the same work. Every hours, every patient's oxygen will be checked out. So by that, we are saving a lot of oxygen. Oxygen audit of all the hospitals has been done. This was the railway, the which experiment was done in Nandurbar. In the summer region, you can see those jute bags which were keep on the rooftop, and water coolers, small water coolers kept on this window side. So the temperature, which was very hot, more than 40 to 43 degrees Celsius, but because of all this Indian jugaad system, we were able to reduce the temperature by more than 15 degree. And I just said, in the Nandurbar, to put patient on the home isolation is extremely difficult. Many times that patient can transmit the virus to so many other people. So because of this isolation facilities, we were able to cut down the transmission, and we were able to reduce the per day caseload from 1200 to less than 100. This was the dedicated women hospital. These were the ambulances. So as I said, we were having a lot of issues of vehicles also, ambulances also. So we got, till date, we got 42 ambulances from different sources, out of which 28 ambulances we got from CSR, others we got from government. So because of this ambulances, not a single complaint, because all ambulances are GPS tagged, they are properly monitored. If anybody got some issues, they will call the control room, and ambulance driver, instead of patient coming to the hospital, ambulance driver will go to the hospital and they will pick the patient. Similarly, vaccination as a tribal bed is a very big challenge for me, because people were very apprehensive, fearful. They were not ready to take the vaccines. So instead of people coming to the vaccination center, we deployed 17 school buses, 16 vaccination teams, and they will go village to village. They will take the camps there, because to register in the COVID app is a very difficult thing. So our teachers, our headmasters, ASHA workers, ANM, they will help them to do the registration. And because of that, right now more than 210,000 doses were administered to the villagers. This is the graph that I was explaining. By 5th of May, the target of the from caseload of 1160 to 1200, it gone to 240. Currently, since last 10 days, it is coming by 50, 60 or less than 70. And this is how the death rate also reduced from 13.33 in the last May 20 to it's now less than 1.70. And this is the infrastructure that we were able to develop. RT-PCR, now we were having 0 initially in the April 2020. In April 2021, we have 2. Oxygen beds were only 20, now 278 oxygen beds. ICU beds were 0, now 60. And I am not explaining about the private setup. Its private setup is completely different. I had to put on more than 7,000 isolation beds, 57 ambulances. We were having only 2 MD doctors initially. By motivating people, 4 MD doctors came. Similarly, other health infrastructure. And this is the conclusion: everyday follow-up, setting up the target, proper SOP, pulling up resources, manpower training, building up testing facilities, strengthening health infrastructure, and creating awareness using mainstream media. So thank you very much for giving me the opportunity. I'm ending my presentation here.